Hi, good morning, everyone. Nice to see you all. Thanks for coming to Grand Rounds today. Hope you had a chance to get some good downtime over the 3-day weekend. And welcome back to Grand Rounds. And so I will turn it over to Dr. Levin to introduce our speaker.
Thanks, Dr. Thomas. Good morning, everyone. And welcome to Dr. Marcellino. Dr. Marcellino is a graduate of the Mount Sinai MD PhD program with a PhD in neuroscience. She subsequently completed residency in Hematology Oncology fellowship here at Mount Sinai as well. And she's been working closely with the clinical and basic science teams within the myeloproliferative neoplasms and leukemia programs, collaborating closely with Drs. Hoffman and Mascarenhas since the beginning of fellowship. In 2020, she transitioned to junior faculty in the Division of Hematology and Oncology and is active in both the clinical and research arenas. Clinically, she serves on the inpatient leukemia service and has recently opened a clonal hematopoiesis clinic dedicated to the evaluation and surveillance of patients at high risk for the development of leukemia. She has opened her own laboratory dedicated to elucidating mechanisms driving leukemia pathogenesis and progression, with the goal of establishing novel therapeutics for these diseases. In addition, she directs the Hematological Malignancies Tissue Bank. She's received multiple awards and has received funding from ASH, the MPN Research Foundation, and the Leukemia Research Foundation to pursue these projects. She's published productively on both basic and clinical aspects of hematologic malignancies and serves as a co-investigator on multiple AML trials. Today, Dr. Marcellino will be presenting her work on her clinical and research pursuits to treat and potentially prevent leukemia. Thank you very much for joining us today, Dr. Marcellino.
Thank you so much. I want to thank you both, Dave Thomas and the medicine team, for inviting me to be able to give this presentation. It's really a distinct privilege and pleasure to be able to present. I've sat in the chair and now on Zoom for a long time, watching Grand Rounds through training, and have seen many inspiring presentations, and I'm excited to be able to present my work. I like to just start off by saying thank you to my mentors, and I'd like to really recognize Barbara Murphy at this point. She served as a mentor for me during all of my training and really still remains as a role model to me as I embark on a translational career. I'd also like to thank Dr. Mascarenhas and Dr. Hoffman for bringing me into the world of leukemia and for all their support. So now for chipping away at leukemia, I have no financial disclosures to report. The objectives of this seminar will be to describe clonal hematopoiesis and the clinical risks associated with it, to differentiate between CHIP, CCUS, and a myeloid malignancy. So just as an overview of my long-term goals, what I want to do is to really be able to go after leukemia by incorporating both endeavors of the bench and bedside. And this will mean taking a true translational approach where you take clinical experience and patient data linked with preclinical laboratory studies, and therefore work towards the prevention and treatment of leukemia so our patients can live to a nice old age in a healthy manner. So the outline of this talk is first to go into what clonal hematopoiesis is and how this eventually leads to leukemia. Second, I want to focus on targeting the p53 pathway in leukemia and its progression. And thirdly, how to prevent leukemia. So to start with some definitions and some backgrounds. Acute myeloid leukemia, known as AML, is the most common leukemia in adults with an incidence of about 4 in 100,000. The estimates for leukemia in the United States for 2022 are about 20,000 new cases of AML, with about 11,000 deaths from AML, and the majority of AML occurring in adult patients. The median age at diagnosis is about 68, and the 5-year survival rate is about 25%. Mortality exceeds 90% when the age at diagnosis is greater than 65. We have a risk classification system by cytogenetic and molecular abnormalities. About 25% of cases of AML are secondary, meaning that they come from either previous myeloid disease or they come from a specific therapy that a patient has received for either rheumatologic disease, gastroenterology, a GI disease, or solid malignancy. So the long road to acute myeloid leukemia. Some patients, a minority, have a germline predisposition to acute myeloid leukemia. This includes patients with p53, DDX41, GATA2, and RUNX1 mutations. Then There are a subset of patients who can get secondary leukemia from a more chronic form of leukemia, including myelodysplastic syndromes and myeloproliferative neoplasms. About 20 to 30% of chronic leukemia patients progress to acute myeloid leukemia. It used to be thought that that if you did not have a prior chronic leukemia, that you had what was considered de novo acute leukemia. However, it is now known that there is actually a predisposition to AML, and that is known as clonal hematopoiesis. About 1% per year of patients or individuals with clonal hematopoiesis will develop acute myeloid leukemia. They can also develop chronic leukemia and then subsequently develop AML. There are a variety of risk factors for clonal hematopoiesis, including aging, chemotherapy, smoking, diabetes, infection, various forms of inflammation, and germline predisposition. And we are certain there are more that will be found in the coming years. As a review of normal hematopoiesis, we are all born with a reservoir of multipotent stem cells that give rise to both myeloid and lymphoid progenitors, which therefore give rise to our three cell lines, including platelets, red blood cells, and white blood cells. The origin of leukemia is clonal hematopoiesis, which I will sometimes refer to as CH. It is the expansion of one lineage of cells, a clone, disproportionately over others. There is a fitness advantage for mutations that allow for the expansion of one hematopoietic stem cell at a higher rate compared to other clones. And this can be due either to an increased self-renewal of the stem cell state, increased proliferation, or reduced cell death. These hematopoietic cells have been found to travel to different tissues of the body and cause abnormal activation of molecular pathways in differentiated cells such as macrophages. This can lead to aberrant immune and inflammatory states. Clonal hematopoiesis can occur in either the lymphoid or myeloid lines, and this has actually been recently explored. Initially, it was only really determined to be in myeloid progenitors, but now there has been current research differentiating between the two. When you have myeloid CH, this occurs there are somatic mutations that occur in genes that are related to myeloid malignancies. Lymphoid, you have corresponding mutations in lymphoid genes. For this purpose of this talk, we will be focusing on myeloid clonal hematopoiesis, because this is where the most research has been done at this time and where my research interest lies. So what drives the evolution of clonal hematopoiesis to AML? You start off with normal stem cells, and then it is believed you get a pre-leukemic stem cell, which is CH, that allows for enhanced self-renewal. Mutations in epigenetic modifiers and metabolic genes such as DNMT3A, TET2, and IDH1/2 are related to enhanced self-renewal. Then with subsequent secondary mutations, such as those seen here, you get enhanced proliferation and clonal expansion that leads to a full leukemia. So clonal hematopoiesis is considered aging not so gracefully. It increases with age, particularly after the 5th decade of life. It is present in about 10% of individuals at the age of 70 years old. This is, again, gradual clonal expansion of stem cells carrying specific disruptive and recurrent genetic variants. And it is in individuals without a clear diagnosis of hematologic malignancies. The variant allele frequency, which is representative of the number of mutant alleles, can range between 2.5 to 10%. It's equal among males and females. However, males are more likely to progress to hematologic malignancies. Clonal hematopoiesis increases the risk of hematologic malignancies, cardiovascular disease, and mortality from non-hematologic cancers. The increased all-cause mortality hazard ratio is 1.9. It is not a disease, so it should be referred to as individuals with clonal hematopoiesis and not patients. Now, there is an alphabet soup as far as acronyms that are associated with CH. CHIP is considered clonal hematopoiesis of indeterminate potential, where you do not have any sign of clinical disease, meaning that there are no cytopenias present, but you do have the presence of a somatic mutation. CCUS is clonal cytopenia of undetermined significance, where you both have a cytopenia and a mutation. And then ARCH is a more generic term that basically is related to age-related clonal hematopoiesis. Importantly, CCUS at 10 years has a 95% probability of progression to a myeloid malignancy, which is important when you think of developing clinical trials. Again, individuals with these conditions do not meet diagnostic criteria for hematologic neoplasm. The cytopenia cannot be from a known cause. It has to be unexplained. The cytopenia is usually anemia, and the mutation should have relation to a hematologic malignancy. The variant allele frequency is usually at least 2%. Of interest, though, is microchip, which is considered having a VAF less than 2%, is present in the majority of individuals greater than 50 years old. Now, for myeloid chip mutations, this is representative of a typical panel. The two sets of mutations I want to point out are both these epigenetic modifiers, which include ASXL1, DNMT3A, and TET2, which account for greater than 90% of the cases of CHIP. Of interest to my research are mutations in the DNA damage response pathway, and that's TP53 and PPM1D, which occur in up to 5% of patients. Pre-leukemia. So as we said, CHIP can lead to several different hematologic neoplasms. What's important to note is that the majority of CHIP will not lead to leukemia. There's an increased prevalence of leukemia in CHIP patients, however, with a relative risk of about 10 to 35. It is more associated with secondary leukemias following chemotherapy, where the 10-year risk is 14% versus 4% without CHIP. Interestingly, there's decreased survival if CHIP is found prior to a bone marrow transplant. The more mutations you have and the higher VAF, the more likely to progress. And in the below figure, you can see that this is really a spectrum where you start with a normal bone marrow, get a somatic mutation, can have clinical evidence of disease with a cytopenia, which can then potentially lead to an advanced malignancy. The seminal paper published in 2018 looked at the prediction of AML in healthy individuals. They analyzed peripheral blood samples using deep sequencing, and they looked at 95 pre-AML individuals and 414 control. CHIP was found in about 3/4 of the cases of pre-AML cases versus in only 36.7% of control. There was a median of 7.6 years before the diagnosis. And about 40% of pre-AML cases above age of 50 had a driver mutation with a VAF greater than 10% versus only 4% of controls. Again, telling us that the larger the clone is, the higher the risk there is for progression to myeloid neoplasm. Subsequent data that has come out that shows that clonal hematopoiesis can form acute myeloid leukemia, particularly in the presence of different chemotherapies, including platinum agents, topoisomerase inhibitors, alkylators. And recently, there has been data that has come out that's shown that PARP inhibitors also increase the risk of transition from CH to AML. There were two seminal papers that came out of Sloan Kettering looking at clonal hematopoiesis in solid tumors. The one seen here paired peripheral blood and tumor samples from around 9,000 patients with solid tumors. CH was found in 25% of cancer patients, with about 5% harboring presumptive leukemic driver mutations. CH was associated with increased age, prior radiation therapy, and tobacco use. Both PPM1D and P53 mutations were associated with a prior exposure to chemotherapy, and CH led to an increased incidence of subsequent hematologic cancers. CH with leukemia-specific driver mutations was associated with a shorter patient survival, and it was believed that the P53 mutations at a low level may make you susceptible to genotoxic stress. The second paper that followed looked at cancer therapy shaping the fitness of clonal hematopoiesis, and specifically showed that radiation, platinum, and topoisomerase II inhibitors preferentially selected for mutations in the DNA damage response genes. They also found that the higher the dose of platinum you had, the higher the risk of CH, and that smoking specifically selected for ASXL1 mutations. P53 mutations and spliceosome mutations were high risk for therapy-related myeloid neoplasms. And around 91% of cases that transformed to therapy-related myeloid neoplasm had the acquisition of other mutations, which we had spoken about earlier, that it's basically a two-hit hypothesis. The number of mutations and allele burden were predictive, and they were able to model the risk-benefit of adjuvant chemotherapy, specifically in breast cancer. However, this has not moved into the clinical realm as of yet. And I would be remiss to not mention the association of clonal hematopoiesis with cardiovascular disease, although this is not the main point of this talk. The seminal paper looking at clonal hematopoiesis and the risk of CAD was involved our very own Dr. Fuster. And this showed that carriers of CHIP had a risk of coronary artery disease that was 1.9 times as great as in non-carriers. And this was done in prospective cohorts. Participants with CHIP had a risk of an MI that was 4 times as great as in non-carriers. Mutations in DNMT3A, TET2, ASXL1, which are the most common CHIP mutations, and JAK2 were each individually associated with coronary heart disease. The higher the VAF, the higher the risk of cardiovascular disease. CHIP carriers with these mutations also had increased coronary artery calcification. In some preclinical studies, they showed that hypercholesterolemia-prone mice that were engrafted with bone marrow that was obtained from TET2 knockout mice had larger atherosclerotic lesions. And macrophages from these TET2 knockout mice showed elevated expression of several chemokine and cytokine genes that contribute to atherosclerosis. So that speaks about CHIP in one area of medicine. But it is important to note that within the last several years, there has been an onslaught of research in really every field of medicine and its correlation and associations with CHIP. There is sort of the big picture of clonal hematopoiesis just in generally being a condition of aging. In infectious disease, it is clear that chronic infections drive clonal hematopoiesis. In the endocrinology sphere, diabetes has been linked to clonal hematopoiesis. In gastroenterology, there is evidence that in ulcerative colitis, there is increased evidence of clonal hematopoiesis. In nephrology, clonal myelopoiesis promotes adverse outcomes in chronic kidney disease. And even just at the last American Society of Hematology meeting, we can see that in primary care, they looked at obesity-induced inflammation and how that cooperates with clonal hematopoiesis, how an increased incidence of clonal hematopoiesis in lung transplant recipients involves DNA damage response genes, and that there is an association between clonal hematopoiesis and gout. So there are many areas for collaboration within the general realm of medicine and hematology. The questions that arise from this is who with CHIP is actually high risk for leukemia, for CVD, and potentially for other medical problems? Who needs surveillance and how do we intervene? And this comes to sort of the first part of the translational network, and this is gathering clinical experience and patient data. Currently, I am developing a clonal hematopoiesis clinic. We are starting a prospective database, tissue banking these patients, and forming collaborative studies with medicine colleagues. The Clonal Hematopoiesis Clinic was opened in Union Square in July of 2021. Individuals are referred due to unexplained cytopenias, or if they're found to have a CHIP mutation on sequencing done in various clinical scenarios, including having a solid malignancy in germline screening from bone marrow transplant donors and carrier screenings. It's a collaboration between geneticists, solid oncologists, and hematologists. There's surveillance, the hope for early detection, cardiology risk management, and guidance. Their yearly next generation sequencing and complete blood counts are done. And in this clinic, we're also following individuals with germline mutations that are at high risk for developing myeloid neoplasms. Some different translational research avenues in CH are developing a prospective database because we really need this information to be able to understand who is actually the highest risk. And this will look at the genes that are mutated, the number of mutations, allele burden, and clonal expansion over time, as well as germline susceptibility, clinical history, and what treatments are prone to expanding the clone. As the director of the Hematologic Malignancies Tissue Bank, we're really striving to collect serial samples on these patients, on these individuals with CH. And this will be used for basic science and translational research. And for instance, we'll be working with Minji Bun, assessing the interplay between immune system and CH. Some ongoing collaborative projects are occurring with our solid oncologists looking at radionucleotide therapy in neuroendocrine tumors, with our lymphoma colleagues looking at the effect of cytotoxic chemotherapy on CH, and then working with Lewis Cohen on CHIP and inflammatory bowel disease. So for the second part of my talk, I wanted to speak of potentially how we can target the p53 pathway in CH and leukemia. So to talk about a common mechanism between aging, CH, and cancer, we can talk about the p53 pathway. DNA replication errors occur with aging. Both mutagens and inflammation instigate DNA damage and expansion of malignant clones. Clonal hematopoiesis and cancer are a consequence of aging and environment, and potentially also underlying germline genetics. And the p53 pathway is crucial in mitigating the effects of DNA damage and inflammation. So when we knock out p53 or downregulate p53, this can lead to aging, clonal hematopoiesis, as well as cancer. So the overall hypothesis behind this work, which was started with my work with Dr. Ronald Hoffman, is looking at the downregulation of the p53 pathway through multiple mechanisms and how it drives clonal hematopoiesis and progression of myeloid malignancies. Decreased p53 with aging and also in disease can occur by several different mechanisms. There can be aberrations in the p53 gene itself, including deletions and mutations, or there also can be upregulation of negative regulators of p53, such as MDM2, MDM4, and PPM1D. I am specifically interested in focusing on targeting PPM1D in hematologic malignancies. And for just a little overview that p53 pathway alterations are prevalent in myeloid malignancies, you can see here that both p53 mutations and deletions are seen in a subset of MPN, MDS, and AML patients, and that the VAF of these p53 mutations matter. As far as p53 negative regulators, nearly all of them are increased in the majority of cases of AML, MPN, and MDS. So as a model to look at what is happening with the progression of myeloid neoplasms, I've specifically been focused on MPNs and their progression to AML. So MPNs serve as a great model for progression of myeloid disease. They are clonal stem cell disorders, and chronic forms of MPN, including polycythemia vera and essential thrombocythemia, are prone to progression to myelofibrosis and AML. And at 15 years from diagnosis, you can see that a proportion of PV and ET patients will progress to MF and AML. And there is basically, again, two different types of hits: the acquisition of driver mutations in the stem cell clone, but also a pro-inflammatory environment that promotes expansion of the clone. So p53 and MPN progression is well established. Low allele burden p53 mutations are found in about 15% of chronic MPN patients. p53 loss of heterozygosity and rapid expansion of p53 mutant clones is associated with transformation to AML. In PV and ET, p53 mutations have been associated with a significantly decreased overall survival. And in a genomic classification of over 2,000 chronic MPN patients, it was identified that patients with a p53 mutation were a poor prognostic group, with an increased likelihood of leukemic transformation and decreased overall survival. Both p53 deletions and mutations promote chronic inflammation, which leads to the development of neoplasia in preclinical cancer models. And some great work done by several groups at Sloan and elsewhere showed that you have the development of acute myeloid leukemia in MPN mice. So basically, if you combine a mouse who has a JAK2 mutation with deletion of p53, you get AML, which is seen here. And so then moving on to the negative regulators of p53, MDM2 and MDM4 and PPM1D. So MDM2 and MDM4 have both been shown to be upregulated in myeloproliferative neoplasms. They work together to decrease the transcription of p53 downstream targets, as well as to increase the degradation of p53. So overall, they serve to decrease p53 activity. MDM2 has been shown to inhibit P53 function in a wide variety of both solid and hematologic malignancies, including the MPNs. MDM2 is upregulated in PV-CD34 positive, so hematopoietic stem cells, and inhibition of MDM2 targets these hematopoietic stem and progenitor cells. Nutlins are small molecule inhibitors of MDM2 that are currently in clinical trial for MPNs with promising results. And the first trial evaluating this concept was done by John Mascarenhas and Ronald Hoffman. And early work that I did with the group showed that gain of 1Q in MPNs is associated with transformation of these diseases and appears years prior to transformation and causes an increase in MDM4. So now on to work that I have pursued with PPM1D. PPM1D, which is also known as WIP1, terminates the DNA damage response pathway in apoptosis. It downregulates the P53 pathway by dephosphorylating P53 and stabilizes MDM2, promoting proteolysis of P53. Hematologic malignancies can have exon 6 mutations in PPM1D, which are seen in the figure below. This causes loss of a C-terminal degradation domain that prohibits its degradation. So ultimately, these mutations lead to an increased amount of PPM1D, which can be cancer promoting. And to give an overview of the importance of PPM1D in cancer, you can see here that there are somatic activating mutations of PPM1D and PPM1D overexpression in nearly every solid and hematologic malignancy. Work recently has come out showing that PPM1D is involved in clonal hematopoiesis as well as myeloid malignancy pathogenesis. PPM1D is on the CHIP panel of genes. The prevalence of PPM1D mutations in an unselected population is between 0.5 to 5%. In patients exposed to chemotherapy, it is between 2 and 20%, and it is found in up to 15% of MDS cases. It is specifically associated with therapy-related myeloid disorders, previous exposures to platinum, radiation, and topoisomerase inhibitors. High transcript and protein expression in AML is correlated with poor risk, with reduced event-free survival and overall survival. And PPM1D mutations and overexpression are associated with chemotherapy resistance. The Grunfeld group in the New England Journal of Medicine in 2018 showed that PPM1D is the 8th most common mutated gene in MPN and can occur in all forms of MPN. Our group showed that there's the significance of these abnormalities in MPN, including the mutations as well as overexpression. So about 6% of MPN patients that progress to AML harbored at least one PPM1D mutation, and 3% of high-risk PV and ET patients harbored one of these mutations. Again, all these were truncating mutations in exon 6. Then we also looked at PPM1D overexpression in patients who did not have a mutation and found that up to 42% had overexpression of PPM1D compared to healthy controls. So this clinical patient data has led to preclinical laboratory studies, allowing us to elucidate the role of PPM1D in leukemia and hopefully starting to develop a therapeutic strategy for targeting PPM1D. So the goal of the my laboratory work is to elucidate the role of PPM1D in the pathogenesis and progression of clonal hematopoiesis and myeloid malignancies with a specific focus on MPNs. And I'm going to sort of go through several different model systems that we're using to do this as just an overview. So we're creating PPM1D mutation and overexpression MPN mirroring models by either crossing PPM1D mutant models to JAK2 positive models or doing lentiviral injection. This will allow for analysis of a disease phenotype to see if these mice transform to myelofibrosis or acute myeloid leukemia. It will allow for transcriptional profiling to determine how PPM1D overexpression leads to a change in the transcriptome. And serial transplantation studies will allow us to know how the stem cell is affected by PPM1D overexpression. Primary specimens from both MPN and AML patients can be used to help see how various therapies will interact with a PPM1D mutation. And we have developed long-term cultures where you can plate your primary MPN and AML patient samples on a mouse stromal cells, which allow the hematopoietic cells to survive for up to weeks. And this can allow us to analyze the prolonged exposure to different treatment options. And then working with Irene Papapetru's group, I've been able to develop MPN iPSC lines to determine the effects of the PPM1D mutation on a JAK2 mutant clone. So iPSCs are induced pluripotent stem cells. And what the main way they're developed is you actually take a primary sample from a patient. So here it's an MPN patient who has mutations in these various genes. And through several steps of reprogramming and differentiation, you're able to isolate several different clones that are within the patient sample and really develop cell lines from each of these clones. Of particular interest to us are these two clones. One clone, which contains the JAK mutation, and another where you have both the JAK2 and PPM1D mutation. This will allow for a comparison to be able to see how PPM1D affects the MPN clone. This can be done using proliferation assays, flow, colony forming assays, looking at engraftment to assess stem cell potential, doing transcriptomics between the two cell lines. They can also be used to test different therapies, including standard MPN therapies, as well as treatment with PPM1D targeted therapies. And for just a little glimpse into this, you can see that if we look at the two different iPSC cell lines, and you look at those with wild type PPM1D versus mutant PPM1D, that you have overexpression of PPM1D when you have the mutated form. And on the right-hand side in the bar graph, you can see that the PPM1D mutant leads to the formation of greater number of colonies when you do a colony assay, basically telling that PPM1D allows for clonal expansion and could be a culprit in leukemiogenesis. So then moving on to evaluate PPM1D as a target in myeloid neoplasms, we started off looking at the activity of a PPM1D inhibitor that was made by GlaxoSmithKline using both cell lines and primary samples. And you can see below, there are several different assays we used. In the top part of the pane, you can see that there is decreased colony formation, and colonies are really the formation of hematopoietic stem cells into expanding and forming clones. And you can see that with increasing concentration of the PPM1D inhibitor, you have decreased colony formation. Below, you can see that there's increased apoptosis of myelofibrosis mononuclear cells with the PPM1D inhibitor. And the Western blot in the lower right-hand corner shows us that as we increase the concentration of the PPM1D inhibitor, we have increased P53 activity shown by increased levels of P21, as well as increased amounts of phosphorylated targets of PPM1D, including P38 and H2AX. We are also use this inhibitor to start assessing for synergy between immunotherapies and PPM1D inhibition, as well as with MDM2 inhibitors. This inhibitor showed activity preclinically in numerous cancers. However, it has not moved on to the clinic. Phosphatases traditionally are very difficult to target with inhibitors, often due to lack of selectivity, but there was also mention that this inhibitor had a lack of bioavailability. So we started collaborating with the medicinal chemistry group of Zhang Jin to develop a new type of compound known as a PROTAC. PROTACs are proteolysis targeting chimeras, and essentially they serve as degraders. What they do is they link a protein of interest, in this case PPM1D, with an E3 ligase. This therefore forms a ternary complex, which initiates polyubiquitination of PPM1D, therefore leading to subsequent degradation by the ubiquitin proteasome system. So you're essentially causing degradation of the target instead of inhibition. And there are many benefits to PROTAC technology. Degradation induced by PROTACs is a catalytic process. And due to their efficient dissociation from the protein of interest after promoting this polyubiquitination, it allows for it to be catalytic. So it allows for action at very low doses. And this activity at low doses compared to the respective inhibitor also makes PROTACs less susceptible to resistance mechanisms, such as mutations or increased expression of target protein. It also offers the option to allow for the potential degradation of undruggable targets, such as non-enzymatic protein-protein interaction targets, scaffolding proteins, and in our case, phosphatases. There are currently 3 PROTACs in clinical trial listed below. So just as an overview of our evaluation of PPM1D PROTAC degraders, we can see here using Western blot that PPM1D PROTACs degrade the PPM1D protein. So with increasing concentrations, you can see less and less PPM1D, and that there is upregulation of the P53 pathway seen here. We can also say upregulation of apoptosis. Currently, we have screened over 80 compounds and selected top compounds based on the degree of degradation and its effect on leukemic cells. On the left-hand side here, you can see the percentage change of the PPM1D protein when you treat with the degrader for 24 hours. And you can see that 113 is our winner as far as causing the highest degree of protein degradation. On the right-hand side, you can see how the PPM1D degraders have an effective viability on a leukemic cell line. And again, you can see in 113 that you have the greatest amount of cell death with this degrader. We have also started looking at this activity in primary MPN samples and have shown that there is decreased viability of mononuclear cells and decreased colony formation, as well as decreased colony size when we treat with this degrader. More to come on this. Now, more as a conceptual framework of how to prevent leukemia, thinking of both about clonal hematopoiesis, chronic leukemias, and AML, as well as using the TP53 pathway to target this progression, I want to go through several scenarios. So at what point should we target the P53 pathway? Historically, it's always been to treat acute myeloid leukemia itself, but we've had very little success in curing patients of this with only a 25% long-term survival rate. We could attack chronic leukemia to prevent its progression, or potentially prevent clonal expansion when treating with high-risk therapies, or potentially go after clonal hematopoiesis itself. So for acute myeloid leukemia, could we increase the sensitivity of leukemic cells to chemotherapy? AML patients are often treated with cytarabine-based regimen. It was shown by Icahn et al. That mutated PPM1D or PPM1D overexpression led to cytarabine resistance, and that inhibition of PPM1D overcame this resistance. So here on the left-hand side, you can see the milieu of cells that would be potentially in the bone marrow of a patient with AML. Some are leukemic cells, some are wild type, and some cells overexpress PPM1D mutations. They overexpress PPM1D. And with cytarabine, you get rid of most of the leukemic cells, but not those that are PPM1D mutant or overexpressing. And over time, these remaining cells can lead to relapse or refractory disease. So what if concurrently with cytarabine, we were able to inhibit PPM1D with either a PROTAC or with an inhibitor? Could we then reach cure? Now for a second scenario, could we potentially prevent progression of chronic leukemia to acute myeloid leukemia? And we already have some evidence that this is a good pathway to go after. So nutlins, which inhibit MDM2, have been used so far in MPNs and are currently in clinical trial. And Dr. Mascarenhas and Dr. Hoffman showed in a phase 1 trial of idasanutlin in PV that MDM2 inhibition is clinically active and prevents clonal proliferation. Subsequent clinical results have further shown that this is potentially going after the hematopoietic stem cell. And we have developed an MDM2 PROTAC in collaboration with Jean Jim's group and Alan Shea, and currently are working on that in MPNs. And then potentially, could we also inhibit PPM1D? There is some preclinical data out showing that the pharmacologic inhibition of both PPM1D and MDM2 is synergistic. Now, if we take another scenario, could we actually potentially prevent progression of clonal hematopoiesis to AML when giving certain high-risk therapies for, say, solid malignancies, IBD, rheumatologic diseases? So let's take an instance of targeting clonal hematopoiesis while treating solid malignancies. You have a patient with head and neck cancer or colorectal cancer receiving a platinum-based regimen. Much excitement, able to cure them of their solid malignancy. But what is happening in the bone marrow? If there are PPM1D mutant cells and you give a platinum agent, we know that this causes expansion of the PPM1D mutant clone. And this could potentially lead to therapy-related AML. What if simultaneously we gave some PPM1D targeted agent with the platinum agent and prevented expansion of this clone? Could we prevent progression to therapy-related AML? And as far as whether we can go after clonal hematopoiesis itself, more clinical data really is needed. There are some first steps towards clinical intervention. And as I said before, the clonal hematopoiesis clinic has a goal of really figuring out what patients are high risk to be able to see who is best to target for leukemic prevention and cardiovascular prevention. Not only does the patient need to be high risk, but the prophylactic therapy has to be relatively low toxicity. The current interventions that are in clinical trial focused on clonal hematopoiesis are IDH1/2 inhibitors that are in trial for patients with cytopenias and IDH mutations. It is easier, or it makes more sense to start off with patients with cytopenias because they are such high risk for developing leukemia. And these studies of both anacedenib and ivosidenib are being done at Memorial Sloan Kettering. There is also a study looking at vitamin C in trial for clonal cytopenias. And the thought is with vitamin C is that you're reducing the inflammatory milieu, preventing clonal expansion of mutant clones. And our overall goal is to establish clinical trials at Mount Sinai, and we are currently in brainstorming sessions of what agent to move forward with. So in conclusion, clonal hematopoiesis results from the acquisition of somatic mutations in hematopoietic stem and progenitor cells. CH results from aging and environmental insults. It increases the risk of myeloid malignancies and cardiovascular disease. CCUS is clonal hematopoiesis plus a cytopenia or multiple cytopenias. And CCUS has a higher risk of leukemia than CH alone. The TP53 pathway plays a role in CH and the progression of leukemia. PPM1D is a negative regulator of P53. And targeting the P53 pathway is one potential mechanism for preventing leukemic progression. PROTAC degraders are a new therapeutic class of compounds under investigation. The CH clinic is open at Mount Sinai and taking referrals. And in conclusion, I'm really interested in collaborating with anyone who is interested. There's so many different populations at Mount Sinai that would be very interesting to move forward with in collaborative research. So please feel free to reach out to me. I'd like to acknowledge everyone in the MPN and leukemia group, all the clinical science, medicinal chemistry collaborators. I really couldn't be done without all of you, and also for my funding sources below. Thank you so much. Feel free to ask me any questions.
Thanks, Dr. Marcellino. Very nicely done. We do have something in the chat already from Dr. Greenberg. You want to read it or want me to read it?
Do you mind reading it?
Sure. It is known that certain occupations have exposures to various toxins and or leukomogens. Do they also have increased CHIP or abnormal mutations? Also, have astronauts, especially those spending months in space, been studied, or maybe mice been studied?
Yeah, so great questions. So definitely there's an increase of myeloid neoplasms, and we've specifically seen this with MPNs as well as MDS with different exposures. So actually, Eileen Sigliano, Ronald Hoffman, John Mascarenhas, and I are interested in looking at this in the World Trade Center cohort because there appears to be an increase incidence of leukemia in these patients. And that was some work done by Emanuela Teoli. So that is definitely one exposure that is sort of a great cohort to be able to unravel the progression of potentially CH to myeloid malignancies. Astronauts are currently being studied. And there does appear that there could be an increased expansion of mutant clones in these patients. So I think more on that to come, but we actually have some friends who are doing research in this area, and it's a very cool topic. And as far as in mice, there are currently clonal hematopoiesis models that are being used. And the problem with this is it's a relatively new area. So Grant Challen is one investigator who has CH models that are being used. Currently, I am just using MPN models as sort of an early form of leukemia to help us better understand the mechanisms that I've discussed. But we're hoping to also move into these other more primitive models of CH.
Great. There's another question and comment, Bridget. Wonderful talk from Dr. Chen. Are PROTACs difficult to deliver to the right cells? Do they have significant side effects on normal cells too?
Yeah, so this is interesting and sort of an active area of development. So I didn't go into the specific of the linkers and ligands that are necessarily used for different PROTACs. So you can use different ligands in the PROTAC to help sort of specify which cell you want it to go to. So currently, there are two different ligands that are being used, VHL and cereblon, and dependent on, a lot of different types of cells use both of them, but there can be differential expression of these ligands. So you can try to tailor it to be able to go to a certain cell population. Now, preclinically, there's also work looking at linking PROTACs to a folate molecule to be able to target it to cells that have high folate expression. And it's clear that cancer cells have high folate expression. So this is also a differential way to be able to target cancer cells. And we're currently looking at this at MPNs to see if this is a potential way, because obviously, when we're targeting hematopoietic stem cells, we're trying to avoid getting the normal stem cells. Otherwise, we'll end up in having exhaustion of the bone marrow. So this is an active area of interest to us. As far as currently in clinical trial, there's not data yet out of whether there are significant side effects from this. We do know that they can be used generally at much lower concentrations than inhibitors due to their catalytic activity. So there's potential that you can mitigate potentially having the same side effects just based on the lower doses.
Dr. Kohler asked, should early CHIP patients have stem cell collections in case they later develop leukemia?
Yeah, so this isn't going to be, it's a wonderful question, sort of an area where we need to figure out, again, who is high risk and whether this could be a potential way to help prevent disease. So, there's already motion in some patients who have germline mutations to really try to potentially set them up for transplant before they progress to an MDS phenotype or to leukemia, but that is particularly in germline. As far as CHIP, there is no motion so far to that, and that is mostly because actually risk stratifying them is not entirely clear at this point. Although I would imagine in the future, patients who potentially have very high VAF of P53 mutations would be the group that you would want to consider for transplant. But it's hard to be able to know whether to collect them at an early stage because you don't exactly know who is going to progress to a higher VAF. With that said, there is sort of conflicting evidence of CHIP in bone marrow transplant donors. So bone marrow transplant donors who have CHIP and the patients that receive these transplants, there is some evidence that they're at higher risk for getting leukemia down the line. But then there's other data to show that there's potentially better engraftment, and the jury's out about graft versus host disease. So the area of transplant in these patients is sort of an open topic, but yeah, it'll be very interesting to be able to figure this out in the future.
Other questions, comments? As people are, there we go. It's from Dr. Kohler. Is there anything to be learned from radiation exposure and leukemia?
Yeah, so definitely radiation exposure increases your risk of having clonal hematopoiesis, particularly in DNA damage response genes, so P53, PPM1D, CHEK2. And we know this also from early data of patients with non-Hodgkin's lymphoma who got radiation, increased risk of leukemia, and also in some of the solid malignancies. Currently, there is no sort of mechanism of reducing the risk of clonal hematopoiesis in these patients, but it's an active area of research.
Anything else? I would say, Dr. Marcellino, that you mentioned your mentors on the phone that are on Zoom now, and congratulations to both of you on this terrific work. But I would also say that your other mentor you mentioned, Dr. Murphy, I have no doubt, would have wanted to unmute and say how proud she was to see you come from as an intern and do all of your training here, and then to now be on faculty and present this terrific work that you're doing. So congratulations to you.
Thank you so much, and thank you for the privilege.
Absolutely. Well, thank you, everyone. Thanks, everyone, for coming today. Have a great day. Stay warm. Take it easy,
Bye.
everyone.
Happy New Year, everyone.
Thank you, Bridget.